and welcome to IHW Council's web series on RH negative incompatibility and isoimmunization. I'm Anisha Nair Thavan, and you're watching an exclusive show on RH negative blood group and its impact on pregnancy. Now, a healthy pregnancy is a celebration for the entire family to welcome in a new member. But there are a few things that would-be parents should be aware of when they start planning a family. One of these issues is RH incompatibility. This occurs when a pregnant woman whose blood group is RH negative, say for example B negative, is exposed to the RH positive blood from her fetus, say B positive. Because of this incompatibility, the mother develops RH antibodies, which have the potential to cross the placenta and attach or destroy the fetus's red blood cells. This causes the fetus to become anemic, and in severe cases, the baby may need special blood transfusions called exchange transfusions even before birth, which are called the intrauterine fetal transfusions, or maybe even after delivery. So today we're going to talk about RH negative blood group and its impact on pregnancy. And to guide you for this and to answer all your queries on this, we are now joined by Dr. G Shailaja, Professor, Head of Department of Obstetrics and Gynecology. She's also retired principal of Osmania Medical College, Hyderabad. Welcome to the show, Dr. Shailaja.
Thank you, Anisha, for the kind introduction. I hope it
Yes, we can hear you loud and clear, ma'am. But before we begin our conversation, I would request our online viewers to keep sending us their queries on the comment box of this live post, and we will try to answer as many questions as we can over the next 30 minutes. To type them in, do like and comment with your feedback, and do share this special show with your friends and your family if you think that they will benefit from this. So share it on your wall, share it on their social media handles so that they come to know about this. So let's begin the show, Dr. Shailaja, and talk about this whole issue about RH incompatibility. Now, I try to explain what I understand about it, but in your practice, since you've been doing this for such a long time, how does this really show itself? I would think most people know their blood groups. Is this a problem? Have you seen this in your practice? Do people know their blood group? Do they know? Are they aware about this isoimmunization problem?
Not many know about isoimmunization, but most of them know that the blood group has to do something with the condition of the baby later. So most of them, because they come and tell us that I and my husband's blood group is the same. So if it's the same blood group, do we have a problem? That's what they are aware of, but they don't know something as RH negative. But they know there is something in the blood group which causes a problem to the baby. Vaguely they know. So we have to tell them that this RH negative, which is also done with your blood group, is very, very important so that it can prevent problems in the progeny. And we have to tell them that they have to know that prevention is always, always better than cure. And this COVID-19 has given us a lot of, lot of knowledge telling us how we have to prevent it. We have to be healthy. So similarly, there is a prevention. 100% you can prevent your baby from having all the complications of RH negative isoimmunization. So if they are aware
what are the complications? And I mean, where does the problem stem from? Is it because
actually what happens when the mother is RH positive for the first time, if she is carrying the baby for the first time, it is called the primary sensitization. That means if she's carrying her RH, supposing she's carrying an RH negative baby because the husband is positive, she is negative, and the baby is RH positive, the baby's blood, there is from the mother, all of us know that the mother supplies blood to the baby and the nutrition, which goes through the blood. And so because the blood, the group of the baby is different from the mother, they develop some certain antigens. And these antigens will cross back to the mother and they live inside the mother. So the first pregnancy, she won't have any problem because it only sensitizes that. It tells, there is something different is going on. So the mother knows that there is something different happening and that memory is there in her blood. So the next time she delivers this baby, fine, and she doesn't take any prevention of anti-D, Then when she's pregnant the next time, this is there. Her blood remembers something was different. So now the second time again she's pregnant, they know this is different. So those different cells or the abnormal cells, which we call them antibodies, they reach the baby through while they are supplying blood. These different, well, they say I am different. So they go to the mother and the baby says, this is different, it's not my mother's. And these cells kill the baby's RBCs. So the mother cells, the baby identifies as not something which is its own, which is helping it. These different cells identify the baby as something foreign.
Alien
Or foreign. So those cells, they kill the RBCs. And these different cells which the mother is sensitized, the second time is called secondary antibody formation. And these secondary cells, time when they enter the baby's blood, they destroy the RBCs, baby's RBCs, which leads to all the complications in the baby. So the first time, if you're giving a proper prevention injection, then the baby won't have complications. So another next thing what you would like to know is it only after delivery do they get sensitized? No, the first time they get sensitized is maximum is during the delivery. That time a lot of fetal blood goes back to the mother's circulation after the delivery of the placenta. So that's why it is maximum during the after delivery of the placenta. But in small amounts, like you get injected with small amounts, you become allergic to small amounts of other articles which you use, like deos, perfumes, anything, you get sensitized, you get allergies. So similarly, even in early pregnancy, if she has a small bleed, supposing she has bleeding or she aborts, even then she can become sensitized. All these are called sensitizing risks, sensitizing events. So any abortion, anytime. And then if they're doing some procedure on her, like art procedures where they are amniocentesis, or if they are doing an abortion, or she has an ectopic, the pregnancy is in the tube. So all these things, any procedures done during pregnancy will also can lead to her sensitization. So
right. So ma'am, my question is
sensitizing events.
Right. So ma'am, my question is that the risk only exists if the mother is RH negative and her baby is RH positive.
Yes.
Now, what is the chance that this happens? The sensitization happens. It could be that her baby is also RH negative. So what is the percentage in your practice have you seen that this complication arises?
In India, it is very low. Around the world, it's 15%. In India, it's only 5 to 8%. But even one baby, why should we lose even a single baby? Statistics says it's 8%, 5 to 8. But for that family, that baby is their only baby or only child. So even if it is 5%, you say it's very low, why should we do all this? It is low. But for that particular family, her obstetric history is gone. She may not be able to have a healthy baby or a normal baby. So though it is only 5 to 8%, and we have means to prevent it, why should we not use it? So when we can, and it's very low. In India, it's of course low, but
right.
Other places
so, Ma'am, you said that this sensitization happens when a little of the baby's blood mixes with the mother's blood, which the chance is high during a natural normal delivery. Is the same risk there when a mother undergoes a cesarean and her baby is RH positive and she is RH negative?
Yes, any delivery, be it cesarean or normal, or you apply a forceps or Ventu, and even if the baby dies in utero, if it is a death, even if the baby is born dead, also this happens. And not only delivery, even it happens even if it's an early abortion, even if it's 8 weeks, 10 weeks, 12 weeks, 14 weeks abortion, or if she just has some pain, uterine contractions. So we call it uterine cramps. Even if for no reason, suddenly they may have uterine cramping of the uterus. And if this cramping causes pain, that little contraction of the uterus also can lead to the fetal blood going into the mixing with the mother's blood and cause sensitization. So any small event also can cause this. As simple as a uterine contraction, throughout any time during pregnancy.
What about spotting or
Even
a little bit of bleeding during pregnancy?
yes,
Some women have, they've carried something heavy and suddenly a little bit of
yes,
spotting
any
happens.
spotting, any bleeding, any even if she doesn't have bleeding, even if she has cramps, then also there is
A
sensitizing.
risk. Okay. So, ma'am, you said that the first pregnancy usually there is no complication. It is
Yes.
during that time that there is sensitization that happens of the mother's blood. So then, when is the step to be taken so that such a complication doesn't arise in a subsequent pregnancy? Is
Yeah.
it after the delivery? Is it after you have conceived? When is this preventive step taken?
So there are two things in pregnancy. One is the antenatal prophylaxis and the other is postnatal prophylaxis. Antenatal means during the pregnancy, anytime. So we don't know, you miss that you have some contractions, but you don't tell your doctor and the doctor doesn't ask you, did you have pain? You think it's some abdominal pain or some gastritis and you fail to mention to your doctor. But it still there is some a sensitization occurs. All these occur after the 28th week of pregnancy if there is no bleeding also. So when it is there, you have to give. That's why we give it during her pregnancy around the 8th month of pregnancy, 32 weeks, and one is after delivery. So
And
even
this
if
is the
we have missed,
subsequent pregnancy, right? The second
yes,
pregnancy.
no, first pregnancy itself.
Okay.
First pregnancy, we give it to prevent for the second pregnancy. If you already have sensitized in the first pregnancy, you're already immunized and your antibody will not work when you give. It doesn't reduce the drugs or destroy the already bad cells. It can only prevent it becoming bad. It cannot destroy the bad things. The cells are bad. The
But ma'am,
antibodies.
during the first pregnancy, how do you know the blood group of the child? How do you know that there will be a sensitization that happens? Because
Yes, you
the
can
baby is
prevent
still
the
in the uterus.
sensitization by giving this antibody, even in the antenatal period and also in the postnatal period. Both. You can prevent sensitization 99.5%, almost every
But
patient.
ma'am, you're saying that you would take this preventive action without knowing the baby's blood group.
Yes, that is antenatally without knowing, postnatally after knowing. But in some cases, in some places, supposing you cannot you can't do the baby's blood group. Supposing there is no facility or midnight and you can't get it done or there's some problem. You can't then, if you know the father's blood group, father is positive, mother is negative. So there is a 50% chance that the baby must be positive. So we don't want to take the risk of the next pregnancy getting sensitized. So in few cases, we give antibody even though we don't have the facility to do the baby's blood group. But routinely, it is a must that you get the baby's blood group done. If the baby is positive, within 24 hours, as soon as possible after delivery, you give the antibody to the mother. But if you can't get the blood group report within a day, doesn't mean you should not give. You can give it up to 1 week because the first time the sensitization occurs very slowly, not like in the second pregnancy where it is very, very rapid. And in the first sensitization, you will need a little more blood for sensitization. Whereas in the secondary, when the second pregnancy, as small as 0.05 ml blood also can give rise to large number of antibodies, which can kill the RBCs.
All right, ma'am, we've started getting some queries from viewers. A Facebook user is asking, can RH negative cause complications during pregnancy? Now, you spoke about complications, but can you tell us how does this impact the fetus? And is there any impact on the mother's health as well?
Yeah, in RH negative pregnancy, if the mother is already, that is in the first pregnancy, there will not be any problem either for the mother or the baby. But if she hasn't taken her anti-D or then she's sensitized, then the second pregnancy, the baby will be the first one to be affected. And whatever the baby has, the problems the baby has, we call it a mirror effect on the mother. The similar things will happen to the mother. Baby is anemic, mother will be anemic, and mother will have hypertension, mother will have blood pressure, and then she will have a lot of swelling. Baby also will swell up, and we call it the hydrops fetalis because there's a lot of fluid filled inside the baby. So similarly, there'll be edema, swelling of the feet, face, abdomen in the mother. So it's a mirror image in the mother. So whatever the baby suffers, similarly it happens to the mother from the second pregnancy. If she's not taken her anti-D, definitely she will suffer. She will have the second child will be born alive, but the baby will have congenital anomalies. She may be born blind, deaf, mute, or some absence of any organ. All these, any congenital abnormality, or she can have less intelligent quotient, she can be cerebral palsy, anything can happen. And the baby can become very severely jaundiced after baby is born. And if the jaundice is more than 19, it will affect the baby's brain, and the baby can have convulsions, and the baby's intelligence is reduced. So the baby can become less autism or slow learners. So many things can occur in the baby if you don't treat that jaundice immediately.
Right. Ma'am, another Facebook user is asking, why does RH incompatibility occur in a woman? Ma'am, the question is, why does RH incompatibility occur in a woman? Is the condition fatal for both mother and child? How serious is this?
Okay, it's not fatal for the mother, but it is fatal for the child. It is fatal.
It could be fatal.
Yeah, it could be fatal depending upon the degree of the antibodies, degree of how much the baby is anemic. For that, we have a lot of investigations we do at the mother is pregnant. When we know, she tells us she hasn't taken her anti-D in the previous pregnancy. So this pregnancy, we do a lot of tests for the mother to know whether really the baby is affected or not. So luckily, God has helped us also. 53%, even if they are sensitized, the baby is unaffected. 53% of children born to sensitized women will be unaffected. The other 50%, only 47% are affected. So we have a lot of tests now, which we do right from the time she is pregnant. We go on repeating those blood tests, and we know, and we can pinpoint when the baby is getting affected and how much the baby is affected with our scans, Doppler, and blood tests. We know how much the baby is affected, when is affected, whether it is the same, whether the readings are the same, then it is not progressing. The disease is not progressing. If your titers are higher and higher levels you get, you know the disease is progressing. So we know what to treat. There are a lot of treatments available even before the baby is born and after the baby is born.
Right. Ma'am, another question that is coming is, does knowing your partner's blood type before marriage help in avoiding this condition?
No. Before marriage, yes, it's good to know the blood group, but it will not avoid the sensitization. Sensitization will occur only in pregnancy, and you can avoid it only by immunization. There's nothing which will prevent the immunization, getting it sensitized, except immunization.
Right. But I think the question is that should you then consider the blood group of your partner? Because, in the end, it's important, but should it be a factor in making a choice? Because in the end, you are saying that this can be prevented by taking the steps at the right time.
Yeah. So if she can get hold of a RH negative partner, fine. Then she won't have this problem. So,
all right.
You want to, like you match horoscopes, you match your blood groups.
Right. Ma'am, we have a question coming in from another user. Can an RH negative man and an RH positive woman conceive a child with medical intervention? I mean, is medical intervention needed? If the mother is positive, is there ever any problem?
There will not be a problem. If the mother is RH negative, only the problem occurs. If the mother is RH positive, there is no problem.
Ma'am, do such patients, where the woman is RH positive and the man is RH negative, need any medical intervention for a pregnancy?
No, not for RH sensitization. Maybe some other causes if they have, but they will not have an RH sensitized pregnancy, and their babies will not be having any problems.
Right. Now, another question coming in from a user is, can anti-D shot prevent further pregnancy loss? The assumption perhaps is that, one underwent a pregnancy loss and wouldn't want something like this to happen again. And maybe the
Yes.
pregnancy loss is because of the RH incompatibility.
See, supposing she is not sensitized, it will prevent the loss. But if she is already sensitized, RH anti-D will not help. So we have to catch them early before the red cells are coated with these antigens. Before they are sensitized, then only the anti-D will help. That's why we are not taking a chance, and we're giving the anti-D even during pregnancy, after the 30th, 32nd to 34th week. And we repeat it again after delivery.
Right. And this, which you're giving during 32 weeks and after delivery, will protect the baby, right?
Yeah.
Right.
Because if supposing she's sensitized because she had some bleeding or some contractions, even if we give after, there are many women who come back to us. They deliver in corporate hospitals and they say, I have taken the anti-D, total anti-D, but still I am having this sensitization and now I'm losing this baby. Then we ask them, did you take in the antenatal period? They say no. If they don't take during the antenatal period, they can still 5 to 10% have, in spite of taking a post after delivery, taking the anti-D, they can still have the problem of
sensitization.
Yes, sensitization and baby being affected. In spite of
what is the course here? Yeah, then what is the course? As a mother, I did all that I could do. I took the anti-D after I delivered my first child.
Yes,
perhaps the sensitization wasn't long enough, but I don't want to lose my second child. So what do I do?
She's already sensitized, so we have to treat. Do all the precautions, do the tests, deliver her early, or we have to give the baby transfusions when the baby is in the womb, or deliver them early and do the exchange transfusion after delivery. Because once they are sensitized, it's out of our hands. We have to treat and take a chance. That's why routine antenatal prophylaxis is very, very as important as after delivery.
Right. So, ma'am, can you explain how you manage pregnancies where, the mother is sensitized and the baby could get affected or is getting affected? How are these pregnancies managed?
So now this lady comes to me. She says, I have done the blood group and she's RH negative. And she told me she has delivered in her village and she didn't take any injections. She didn't know that she was RH negative. Then we do a blood test for her called indirect Coombs test, whether it's positive or negative, as soon as she comes, even if 6 weeks, 8 weeks. So we see whether it is positive or negative. If it is negative, we are sure that she has not yet been sensitized. And this test, we have to repeat it every 2 months. I repeat it in the 2nd month, 4th month, 6th month, 8th month. And supposing suddenly she becomes positive, the test becomes positive when she is in the 8th month. Then I know that she is RH negative, she didn't get her anti-D done. So this test I repeat every 2 months. Second is from the 22 weeks, from the 5th month, after the 5th month of pregnancy, we do what is called as the ultrasound scan and the Doppler for the baby. In the Doppler, we see the blood flow through the baby. And one particular vessel, we see the blood flow through that. And if that blood flow is suddenly increasing in velocity, then we know that the baby is getting affected. So that we repeat every 3 weeks if she's normal. And if she's positive, we do it more often. And then depending upon that score, there are scores. We have scores 1.3, 1.5. So depending on that score, we then decide when to deliver the baby, whether to wait till the baby is 9th month or early. So depending upon that velocity of that blood flow score, we deliver the baby early, or if it is very high and she's only 8th month, 32 weeks, we can't deliver. Even after delivery, we cannot save the baby. 28 weeks. If she's a 28 weeker and the blood flow, or PSV, we call it, if it is very high, more than 1.5, we have to give the transfusion while the baby is in the utero. So in utero, we can give maximum of 3 transfusions to the child, baby, fetus rather. Then supposing this 1.5 is reached after she's 35, 36 weeks, we know it is 1.3, 1.4. So we know it is increasing. So we deliver her earlier. By 36 weeks, do the serum bilirubin for the baby, in the baby, and then give an exchange transfusion. We remove that blood and give good blood. So the baby will thrive. So the later you deliver the baby, the later this PSV rises, the baby has a better chance of survival. The earlier they have the problem, prematurity is a major problem, all of us know.
And all of this can be prevented if the anti-D is taken after the delivery.
All these complications in the mother, in the baby, can be prevented by just 2 doses, just like we say, do boond of polio
drops.
Just like that. It is 2 doses of anti-D for every RH negative pregnant woman. If that is our slogan, we can
eradicate this.
Prevent, totally prevent.
Prevent it, right.
Only
we have another...
one or two causes where we can't prevent is supposing this, this patient, when she was in her mother's womb and her mother had some unknown transfusion, RH positive or transfusion, then that baby would have been sensitized when she was in the utero itself. So that what we call is grandmother's theory. Very rare, 0.001%, that is one. And the other is if she has some rare blood groups, Duffy and Fluff, F and E, those are some rare subgroups they have. These are the women which we won't know. We won't know that immediately. We just do RH negative. We don't look for these rare blood groups. But if there is a doubt, then you look for rare blood groups.
We have another question. Both husband and wife's blood group is A positive. Will there be any issue in conceiving and pregnancy or any complication during pregnancy?
No, not at all. They may. ABO blood group incompatibility may be there, but not RH.
Okay.
They won't have any issues because of the blood groups, rather.
All right. Another question is, when would one need to get an antibody screening done?
As soon as they are pregnant. First is as soon as they are pregnant.
And ma'am, what information does this antibody screening reveal?
They'll tell you whether you're sensitized or not. And then if we have a doubt you're sensitized, we do it, the same test, we do it in dilutions. In which dilution is it positive? So that helps us in the treatment. We have a critical level.
Ma'am, another question being asked by a user is, are there any side effects of anti-D?
Not that we know of. There are no major side effects, nor minor, maybe very, very rare. You might have an anaphylactic reaction, some rash or a little mild fever, but not any serious, no. Not like penicillin where we have very severe reactions.
Right. So ma'am, for women who present themselves for delivery in institutional setups, are they willing to take this if they are RH negative?
Yes. If you explain to them these are the problems, they definitely, but you have to tell them why they have to take it, what are the problems, then they take it. Some people, they say, I'm not going to conceive again, I want only one child. So why should I take? Because I'm not going to have my... But then supposing sometimes they might need a blood transfusion in future. So then they will have the hassle of incompatible blood transfusions. They might have reactions. So it is always better they take the anti-D.
All right.
They may be sensitized, and this sensitization, they may not be able to get a proper blood group later on in life when they need. Or sometime later you change your mind, you want a second child. Then you have the problem. So even if you don't want to conceive again, it is preferable for your health to take it.
All right. So ma'am, these are women who present themselves in institutional setups and you are able to give them anti-D after delivery. But, in India, still many births happen at home, midwives assist. And here, there may be no investigation to find this out. And then suddenly if they come to you in an institutional setup and they themselves don't know, then, I mean, how do you help these people?
See, now the government has a lot of schemes like Janani Suraksha and all these schemes where the pregnant woman, there are these Anganwadi nurses, ANMs who go home, house to house. The Sarpanch, they are under the Sarpanch and they make all the home visits. And they have the antenatal card where blood group is stated as necessity. This lady collects the blood and sends it to the blood bank or wherever, whichever district hospital, and they get the blood test done. And most of the PHCs have doctors, and they have mobile vans, mobile dispensaries where they go to the remotest of places. Now everybody, like how they know about polio, they know about blood group, they know about tetanus, which is given in for the pregnant woman. So similarly, whichever doctor, whoever is there in the rural areas, they also know that there is something called mismatched blood. They may not know RH negative, but they know there is some change or some problem with the mother and the father's blood group, which causes the babies to die or that causes the baby to have some congenital anomaly. So not much, but at least 60% know about it in the rural areas also. So I feel that the government has to take it up in a larger way, just like we took up the polio campaign way back 20, 25 years ago.
So, ma'am, if a campaign has to be done, then does it only target women who are RH negative? How is a campaign then done? How can this is our attempt to create awareness, but if it is coming from the government side, will it say that get your blood group tested, know your blood group, and then take, if you plan a family, then speak to your doctor? Are doctors also aware of this condition and proactively ask patients, what's your
Yes.
blood group and things like that?
Because antenatal checkups know that blood group RH typing is mandatory, is essential, and you can prevent a lot of problems because of that. Every doctor and most of the RMPs and other alternative medicine, your Ayush, everybody knows about this in antenatal care. And because you have those antenatal cards where blood group is essential, but the only thing is they don't have the husband's blood group. That also, if it is included in those cards, mother's blood group, father's blood group, then it will be much easier to know.
Right. Ma'am, you said that, to find out if the mother is sensitized or not, you run tests every 2 months.
Yes.
So then the patient will have to present themselves to an institutional setup very often.
They come every month for an antenatal checkup, isn't it?
Okay.
And they already would have they know that once they come the first time, we tell them that you didn't take your antibody, so you may have these complications, and your baby, you can have any problem with your baby also. Once we tell them they can have a complication with their baby, they do come more often. And it's not more often. 1 month is antenatal checkup, and this we are doing only once in 2 months.
Okay. All right. Ma'am, can you explain to us how these tests assess if there is a sensitivity issue? You said if this is the indirect wounds test.
Yes.
What are the readings which are worrisome? How often have you seen these readings very high in case a woman has not received anti-D? What is the percentage of complications that rise because of this sensitization?
Percentage of so once they are sensitized, it's 100% complications. So if it is positive, she's definitely going to have the complications. May be minor, major, minimal, moderate, severe. But if she's sensitized, she's definitely going to have complications. So we have seen the place where I worked is a pediatric and a high-risk maternity hospital. So we had a lot of cases of RH negative where they didn't take the anti-D and they come back positive. Even today, I have a lady who did not take, and she had 3 miscarriages after that, and now she's come for the 4th time. And the last baby also was high drops. They didn't recognize she was in the village. She couldn't, whatever her reasons were. Now she has decided to come and get investigated. All this time she didn't want to come for even the investigations. So it is, but once you're sensitized, you're bound to have complications for the baby. Whether they are severe, moderate, that depends on the degree of sensitization. That's why the first thing is we do is the indirect Coombs. First we see whether it's positive, negative. If it is positive, we do it in dilutions to see if it is increasing. So critical is 1 in 16. If it is above 1 in 16, we know that she's going to have, definitely going to have. If it is less than that, she may not have complications. She may just have jaundice. We have to prevent jaundice in the baby after the baby is born. So we deliver them much earlier. We don't wait till she finishes 40 weeks.
Right. So, ma'am, a mild case is where the child has jaundice, which can be treated post-delivery.
Yes,
and the severe one is the hydrops case, right?
Severe is hydrops in utero. So now latest we have is the in utero exchange transfusion. While the baby.
And how does that happen?
So while the baby, under ultrasound guided, we put in a needle through the baby's groin vessel, through the placenta, and we search for through the vein in the placenta. One vein we take out the blood, the other one we push in fresh blood, 2.5 to 5 ml of the blood. Depending, there are various factors which we have to take into account, the hemoglobin of the baby, and what is her PSV value, what is the bilirubin, what is the hematocrit count, and a lot of parameters are there. And we do the exchange while ultrasound guided. Very few centers do it.
All right. Ma'am, how are these parameters assessed for the baby? Does this involve invasive test again, or is this found out?
We have to draw blood from the umbilicus of the baby using the ultrasound. And then each test, when we draw blood, it's an invasive. So before each test, again, we have to give Antibody.
All right. And ma'am, are these facilities to give intrauterine transfusion readily available these days in our country, or are they only restricted areas?
In all the major metropolitan cities. It's available in Bombay, Hyderabad, Calcutta, Delhi. In the major cities, yes, one center or two centers maybe. One center or two centers in the city. They're very expensive, and the outcome is not very, very happy with the outcome.
All right. So the best way out actually is to take the Antibody at the right time.
Yes. Instead of going through all these complications, which we don't know, because we are going to treat a very tiny baby, maybe not even 1 kg. If she's 28 weeks, and the baby is hardly 900 grams baby. So if you treat a 900 grams baby, we know we are going to end up with a lot of complications. Complications during the infusion and later on. And then even if she's born at term with severe jaundice, again, we have to give transfusion every day. We have to look at the serum bilirubin, prevent the convulsions. So all these problems are going to take a toll on the parents and the baby.
Child. Right.
Prevent. All these are preventable. With just 2 shots of antibody. All are preventable. It's not like that even if you give, we cannot prevent. Like, they are all preventable.
All right. Thank you so much, Dr. Shailaja, for joining us and answering all the questions that you've taken up today. It's a big relief that the Antibody is so effective, and thank you so much for explaining to everyone the critical importance of this Antibody for RH negative women. Thank you so much.
Thank you, and I hope I could clear all your doubts and you did understand what I was trying to tell you. So if you or any of your friends or relatives they know that their blood group is RH negative, please go and meet any doctor. They'll be able to tell you how to prevent the problems. Just 2 doses of Antibody, one during pregnancy after at 30 weeks and not 32, 34 weeks, even if you're a little late, it's okay. And then one immediately after delivery. You will be safe, your baby will be safe, and your future pregnancies also will be safe. Not only now, later pregnancies also. Thank you so much.
All right, Dr. Shailaja, thank you so much for joining us. and answering all the questions that you've taken up. So that was Dr. Shailaja answering all your questions on RH negative blood group. If you have any more questions, you can send them to us through WhatsApp. Just click on the WhatsApp button on our page and send us your questions. We can take them up in our next show. And don't forget to follow us to stay updated on all the concerns about health and well-being. This program was supported by Bharat Serums and Vaccines Limited under its Public Awareness Initiative. We'll be back with a special show on RH negative incompatibility next week. Do follow us on Facebook to get all the updates on our upcoming shows. Do keep sending us all your questions and we will certainly include them in our shows. Till then, stay at home and take care and stay safe. Goodbye and see you soon.